Hello, everyone. Good morning. I would like to introduce myself for those of you that are watching me for the first time. My name is Kliment Anastasovski. I live in Skopje, which is the capital of my country, Macedonia. I work in a private dental office in which I'm one of the owners there, actually. So, since I am a specialist in endodontics and restorative dentistry, I have limited my practice mainly to root canal treatments and retreatments, but occasionally I do restorative work also. For today, I would like to talk to you about a concept that I have integrated into my daily practice, meaning into the field of endodontics and restorative dentistry, and that is the minimally invasive concept. In today's lecture, I'll be more focused in the area of the endodontic treatment and retreatment, or the minimally invasive endodontics. Endodontology, as we all know, is a branch of dentistry that is concerned with the study of the form, function, and health of injuries to inflammation of the dental pulp and periodical region. So, our job is to always try to preserve the vitality of the pulp tissue present, and if that is not the case, or it is not possible to do so, to perform root canal treatments or retreatments so that we could stop the inflammation on reaching the periodicular region while causing periapical lesions. We do that by following the basic principles or steps of the root canal treatment, starting with the establishing of a proper diagnosis, which is a crucial part actually in whole dentistry, but especially in the field of endodontics, because as we all know, most of our patients come to our clinic with a lot of pain that is most of the time spreading to to a whole region, and it is up to us to determine which tooth is responsible for those symptoms by going through some of the examination procedures, like collecting patient medical history, pulpal test, vitality test, periapical test, radiographic examination, and etc., so that we could relieve the patient of its symptoms by providing appropriate treatment. After the establishment of the proper diagnosis, we go for the next step of the root canal treatment, or the access cavity preparation. There are actually a couple of access cavity designs, starting from the traditional access design to more conservative or even ultra conservative access cavity designs. And it is up to us to choose a proper access cavity designs for each and every one of our root canal cases. If we want to stay in the field of minimally invasive endodontics and to preserve as much tooth structure as possible. After the appropriate access cavity preparation is done, then we go further with the instrumentation phase of the treatment, starting with the initial negotiation of the root canals with small hand files, then go with the glide path management using manual files and rotary files with smaller taper, like 2% taper. And at the end, we do the shaping and finishing with the larger tapered rotary files. Regarding the minimally invasive concept, we need to be careful when choosing the size of the taper of our rotary instruments, meaning that if you want to be minimally invasive, we don't need to go above 0.6% taper. And especially when choosing those orifice opener files to avoid the bigger tapered, like 10 or 12%. We all know that this is a chemomechanical process, so we need to keep in mind about the irrigation step of this procedure. So to always fill the root canals, the whole root canals and the cavity with solutions like EDTA and especially sodium hypochlorite to clear out the smear layer, the dentin that is that happens inside the root canals from the instrumentation phase, and also to dissolve the vital and necrotic pulp tissue inside the root canals, so that we will leave a nicely shaped and clean canals for the last step of the root canal procedure, or the obturation phase. Here we need to do a 3D obturation actually to feel all of the root canal system, not just the main root canal system, but all the additional accessory canals, anastomosis, apical deltas, and etc. Since 2009, the American Association of Endodontics, together with the European Society of Endodontology, initiated an update on the endodontic diagnostic terminology, meaning they split the diagnostic terminology into two parts, actually, a pulpal and apical diagnosis. And we did that by following some of the examination procedures that I was talking about earlier, like the medical history, clinical exams, both periapical tests, radiographic analysis, and etc., so that we will determine the diagnosis of the current case, and afterwards that will help us to make a proper treatment plan for this case, which we will execute later on with a safe and predictable root canal treatment. Minimally invasive endodontics actually refers to a concept that advocates the preservation of as much natural tooth structure as possible by, first of all, downsizing the preparation of the access cavity, the taper of the prepared canals, and the prepared apical size. So it refers to the minimally removal of dentin during all three phases of root canal procedure, like the coronal access preparation first, the shaping and flaring of the root canals, and especially the canal orifices, and at the end, the apical canal preparation. We are going to start with the coronal access preparation first. Sorry. So here in this clinical practical guidelines on minimally invasive endodontics, they brought to us the main features to be aware in minimal invasive endodontics, and that they are the first of all, the pericervical dentin, then the 3D soffit, and later on the 3D ferrule. So first of all, the pericervical dentin, or PCD, is actually the dentin near the alveolar crest, roughly 4 millimeters above the crestal bone and 4 millimeters extending apical to the crestal bone itself. Its preservation actually increases the resistance of the tooth, and by that its longevity. So actually, in the minimally invasive endodontics, this area here has a crucial part, especially this precious pericervical dentin that we need to save as much as possible if we want to be conservative. Starting with the access cavity designs first, we need to aim for a more conservative access cavity design than from the traditional one, and we can do that by simply avoiding the straight line access like we needed to do many years ago when we were using not so advanced rotary files that were not so flexible, and we needed to do a straight line access even to the middle third of the root canal, so that we will avoid some of the iatrogenic errors of happening in the instrumentation phase. We don't need nowadays the advancement of the rotary files is great actually from the mechanical thermomechanical perspective. So we can now be more focused on saving natural tooth structure than to be only focused in the straight line access of the root canals, and go, as I said, with the more conservative access design. Also, after the access design, to preserve this pericervical dentin, we need to keep in mind the size of the taper of our rotary files, not to go beyond 0.6% taper, and especially when choosing the orifice opener files, which can go up to 10 or 12% taper, who actually by using them, we will destroy a lot of this pericervical dentin, and by that we will decrease the fracture resistance of the tooth. A soffit next refers to a small portion of the pulp chamber roof that actually is intentionally left intact during access cavity preparation, and by that it acts as a protective layer of dentin around the pericervical dentin, and is a key aspect of minimally invasive endodontics. So once again, we don't need to be using the straight line access in all of our root canal cases. And by doing so, we'll be more focused on the more conservative access cavity designs, and also more conservative rotary files or orifice openers, I will say again, orifice opener files with smaller tapers, so that we will conserve as much tooth structure as possible. And the 3D ferrule here, it actually differs from the traditional ferrule. It contains three components. The traditional ferrule itself, the dentin girth, or the width of the dentin left, which must be 1 millimeter at absolute minimum, but it will be greater to be 1.5 or 2 millimeters in width. And the total occlusal convergence, or the axial walls of the restoration, to be as parallel as they can be, so that it will have a bigger fracture resistance. The restoration will have a bigger fracture resistance. Here you can see all the access cavity designs, starting from the traditional and to more alternative access designs, meaning conservative, ultra conservatives, and even carious and restoration driven access cavity designs. So it is up to us to determine which type of access design we are going to be using for our root canal treatment. But I can surely say that we cannot use one of these access designs to all of our root canal cases if we want to stay in the range of the minimally invasive concept, where we need to preserve as much tooth structure as possible, but to have more individual approach to each and every case that we need to do root canal treatment, so that we will be as conservative as possible. Here I would like to say my opinion on this matter is that from the minimally invasive perspective, I always aim to be in the middle, meaning that I'm not using the traditional access cavity all the times, but also I am avoiding the ultra access cavity designs like this ninja access cavity or truss access cavity design, because in my opinion, we need to be minimally invasive always, but so that we won't compromise the later stages of the root canal treatments, like the shaping, irrigating, and obturating, because in my opinion, actually, and in some papers that we are going to see, using these ultra conservative access cavity designs, we will complicate the later stages of the root canal treatment later on, meaning the shaping procedure, where we'll have a lot of we'll have a high level of complication, the irrigation step also, and later on the obturation phase. So I am all for the minimally invasive access cavity designs, but also to watch out for the other objectives of the root canal treatment, the shaping, irrigating, and the obturating step. Here in this literature review of minimally invasive endodontic access cavities, you can see all the different access cavity designs, starting from the incisors, then the premolars. You can see the design is different in all cases. Here are the molars, upper and lower molars. And in this paper, they have concluded that the application of minimally invasive endodontic cavity designs in clinical practice requires critical consideration by weighing the risks and benefits of the traditional access cavity preparation and the minimally invasive access cavity preparation, meaning that we are aiming to do a minimally invasive access cavity designs, but in that percentage that we won't be complicating the later stages of the root canal treatment itself. The authors here suggested that a few clinical approaches may be adopted here to overcome the problems in chemomechanical debridement of the root canal systems. And they include the increase of the concentration of the disinfectant used as detergents, like using full-strength sodium hypochlorite, the use of irrigant agitation technique, whichever you prefer, sonic, ultrasonic, laser, and etc. Increase the time spent on chemical disinfection, the use of heat-treated night eye files, with, of course, improved flexibility and fatigue resistance, the placement of calcium hydroxide as intracanal medicament for additional disinfection, and of course the use of an operative microscope as a key factor on minimally invasive endodontics. Here in this article on the minimally invasive access cavities, they stated that the truss access cavity and ultra-conservative access cavity are more conservative types, logically, of access cavity, but that badly influence the irrigation process and canal transportation, and especially in necrotic teeth, aren't recommended. So this is what I was talking about before. This is also my opinion that if we use ultra-conservative access cavity preparation, we will be complicating the further steps of the root canal treatment, and that is why I avoid using ultra-conservative access cavity designs. This here is an interesting study on the impact of access cavity design on fracture resistance, actually, on endodontically treated maxillary first premolars, where they have tried to find out which class of restoration, second or MOD, and the access cavity designs is actually decreasing the fracture resistance the most. And here in the results area, they found out that the missing marginal ridges, such as in MOD cavities, played an important role in decreasing the fracture resistance of endodontically treated teeth, and not just only the access cavity design. Here we can see under A, we have a conservative access cavity design, and it is lowering the fracture resistance of the tooth by 5%. Later on, we have the traditional access cavity designs with 20% lowering of the fracture resistance of the tooth. And here you can see where the marginal ridges are lost in the second class restoration cavity, 47% decrease in fracture resistance, and the most decreased resistance in the fracture resistance we have in the MOD cavities, where we have lost 2 of our marginal ridges. After the coronal access preparation, we start with the next step, or the instrumentation step, or the biomechanical preparation as described by Schilder, that involves both biological and mechanical objectives in the preparation of the root canals. And they all actually state that the canal after shaping should have a continuous conical shape with the narrowest cross-section diameter apically and the widest coronally. The walls should taper evenly toward the apex and should be confluent with the access cavity, also to give the prepared canal a quality of flow, so that it will permit the gutta-percha to flow against the wall without impedance. Should keep the apical foramen as small as practical. We'll be talking about this later on. And should shape and clean the canal without transporting the apical foramen. And what about the biological objectives? We need to confine our instrumentation to the root themselves so that we will ensure that the necrotic debris are not forced beyond the foramen and causing flare-ups to our patients. Removal of all tissues from the root canal space and creation of sufficient space for optimal obturation of the radicular space. Here are some of the goals also of shaping and cleaning procedure: the removing of vital and necrotic tissues, the creation of sufficient space for irrigation, medication, and obturation, the preservation of the integrity and location of the apical canal anatomy, the avoidance of iatrogenic damages, preservation of sound root dentin for the long-term function of the tooth, and avoidance of irritation and or infection of the periodicular region. According to Grossman, regarding the instrumentation armamentarium, he divided them into 4 groups, meaning instruments for exploring, debriding, cleaning and shaping, and obturating, which we use for the location of the canal orifices and determine the patency of the canal, to extirpate the pulp and remove any foreign debris, to clean and shape the root canal, and later on to cement and pack the 𝗠𝗏𝗃 into the root itself. Also, according to ISO and FDA, we have 6 groups of instruments: hand use only, engine-driven latch type, night-eye rotary instrument, engine-driven 3D adjustment, reciprocating instruments, and sonic and ultrasonic instruments. So starting with the first group, we have the hand files here. There are a lot of actually hand files that differs from each other from the cross-section perspective. They all have a different cross-section. They give us a great tactile control actually while shaping the root canals, and they are cost effective, but also when only using the hand files, they are time consuming because we will need a lot of time to prepare the canal to its full length only using hand files, and also we need to know a lot of different techniques so that we can accomplish the shaping phase only with hand files. They are inflexible, difficult in negotiating the curved canals, and if not used properly, they can extrude debris periapically and pack the debris into the recesses of the canal. Next, we have the engine-driven night-eye rotary files that are actually faster in shaping in comparison with the hand files, of course, 50 to 70% time reduction. They have better centering and reduced transportation, and that is why they are user-friendly. Also because we don't need to know any kind of technique when using them, just a additional equipment like the endomotor, who will help us to use them. While using rotary instruments, we also will have a better obturation later on in the final step of the root canal treatment. And the cons here, if I may say, is they are at a higher cost than the hand files. The fractural risk here, meaning that the night eye has no indication before fracture, but I always advise you to watch under the magnification of the microscope before inserting the rotary file inside the canal, because sometimes you may spot some unwinding of the file, and then you can, of course, discard it before continuing with the shaping procedure. We have the risk of over preparation here, but that is, of course, if we choose to use the big tapered rotary files. As I said, if we want to be minimally invasive, we don't go above 0.6% taper, because 6% taper is more than enough for shaping the root canals. And about the rotary files, here is the taper lock or the screw-in effect that can happen if we are not using them properly, where the apical part of the rotary file will get stuck inside the root canal and the coronal part will go on rotating, which will lead to a fracture of the instrument inside the canal. but we have the help here to avoid this from the endomotor, which have the torque control and will not let this happen. Next one, we have the reciprocating instruments. In 2011, after 4 years actually of research and development, the Wave 1 and Reciproc were launched as a single file systems. And about the reciprocating motions, as defined, it was defined as any repetitive back and forth motion that has been clinically utilized. That was said by Dr. Ruddle. It gives us the reciprocating files gives us a reduced torsional stress. Actually, there is no binding or less binding inside the root canal. The root canal dentin walls, we have a less flexural stress, reduction of the number of cycles during preparation, and of course the decreased risk of instrument fracture. And that is why it is always advisable for the beginners actually, but for all the colleagues to be using reciprocating files, because they are more safer and easier to use. Regarding the cyclic fatigue of the instruments, of the reciprocating instruments, regarding the cyclic fatigue on the instrument, the reciprocating instruments actually have a great cyclic fatigue resistance, meaning that they oppose the both stresses that happen to the rotary file inside the canal when shaping curved canals, the stretching and extension stresses. We also have the torsional fatigue here. They also have a great torsional fatigue resistance, meaning that they work in 2 different angles, and the smaller angle or the clockwise direction happens to be disengaging the rotary file inside the canal and avoiding to get into a taper lock or getting the screw-in effect, which is a great advantage of the reciprocating systems. About the shaping ability of the rotary files, we have a comparison here on the microcomputed tomography based comparison between the reciprocating single file, in this case F2 pro-taper technique, versus the full sequence rotary technique. And we can see that the approaches were similar, but however, the single file F2 pro-taper technique was marked faster in reaching the working length, meaning that while using a single file to do the whole shaping procedure, we will be faster in that instrumentation phase than using a full sequence. Also, this is another study on the shaping ability of rotary and reciprocating single file systems in combination with and without different glide path techniques in simulated curved canals. And in the results, they stated that in the groups that there was used a glide path file with the reciprocating single file system, there was produced less transportation and curvature straightening than in the groups that there wasn't glide path file used. So this is logical actually, because all of us know the glide path actually, or the tunnel that extends from the orifices of the canals all the way to the apical foramen, acts as the pillar actually in the shaping procedure of the root canals, because we do the 19% of the shaping of the canals with the glide path, with creating the glide path management. Because later on we'll just need to be using larger tapered rotary files that will only follow the path that we have left them with the management of the glide path. And that will give us an easier and safer preparation of the root canals. Regarding the cutting efficiency, I will show you here in this study that the kinematics actually used have nothing to do with the cutting efficiency of the file itself or the capability of a file to remove dentin. And it all depends on the cross-sectional design, number of flutes, chip removal capacity, sterilization, metallurgic properties, and etc. But nothing to do with the kinematics actually. Here is a study on the cutting efficiency of two heat-treated files in rotation and reciprocating motion. Two file system used here, the Fanta AF1 rotary system and the Azure rotary system, and they were used in rotation and also in reciprocating motion. And they here find out that the AF1 rotary system showed higher cutting efficiency than the other system in both rotation and reciprocation, meaning that the cross-section actually here impacted the cutting efficiency of the AF1 file more than the kinematic used. Here in the retreatment cases, of course, we can be using the reciprocating file system in the retreatment cases. This is the review on the efficiency of a reciprocating and rotary systems with or without the ultrasonics in removing root canal filling with, in this case, calcium silicate base sealers or MTA. You can see here above picture B1, you can see the canals here. The obturation was retreated only with reciprocating systems, and later above B2, in this case, they were using reciprocating file systems, and of course, with the passive ultrasonic irrigation. And they found out that the passive ultrasonic irrigation significantly improved the removal of the root canal filling materials, and that the reciprocating systems were more effective than the rotary, but needed longer time than rotary systems in removing calcium silicate-based sealers. So they recommend here the use of reciprocating systems together with the passive ultrasonic irrigation whenever root canal treatment is considered, regardless the use of calcium silicate-based sealers or other. We move forward to some of the controversial studies here on the aspects on the apical debris extrusion. First of all, apically extruded debris generated by canal preparation contains dentin, necrotic pulp tissue, and bacteria, and that is why we need to avoid a lot of debris extrusion apically, so that we will avoid the flare-ups on our root canal treatment patients. According to these studies here, we can see that it is controversial if the reciprocating movement produces more apical debris extrusion than the continuous rotation. There are a lot of studies. Here on these studies, we can see that even they stated that the reciprocating files was found to be the least apically extruded debris system among all the groups, in which there was also a rotary file groups. Here we have the apical debris, a study on the apical debris extrusion of rotary and reciprocating files combined with two supplementary irrigation techniques. So what they found here, they concluded that the irrigation technique actually significantly influenced the debris extrusion, while file systems had no effect. So the use of passive ultrasonic irrigation with both file systems reduced debris extrusion compared to the groups that were using without adjunctive irrigation technique. So meaning that the use of irrigation solution and activating technique plays a greater role here for the apical debris extrusion, and we need to always refill our root canal treatments and pulp chambers with irrigant solution, especially sodium hypochlorite, so that we will clear out that debris after preparation and while doing the preparation of the root canal, so that we will lower the apical debris extrusion and to stop the flare-ups, causing flare-ups on our root canal patients. But in particular, in vivo studies would be valuable because the absence of periapical tissues in vitro studies may have limited implication. Here, another controversial topic on the producement of dental defects or cracks after shaping with rotary or reciprocating files. We have actually the contact between the files and the canal wall creates momentary stress, concentration in dentin that sometimes causes cracks. The reciprocating movement here was reported to reduce the torsional stress by periodically reversing the direction of rotation of the instrument inside the canal or the disengaging of the instrument while shaping the root canal system, and by that it produced none or less dentinal defect or cracks. In this study on microcomputed tomography assessment of dentinal microcracks after root canal preparation with different rotary systems, they stated that none of the preparation system induced the formation of new dentinal microcracks that weren't here before starting the preparation. As you can see here on the right, we have different systems with continuous rotation, reciprocation, and even the self-adjusting files that all work the same way and not producing dentinal microcracks. These are some other studies on the comparison of incidence on dentinal defect after root canal preparation with continuous or reciprocating rotary files, and they concluded here in these studies, actually, they evaluated that all the rotary instruments and also the hand files causes microcracks in root canal dentin, and there is no difference in all of them actually. Regarding the shaping time, as we said before in the part of the shaping ability of the reciprocating file system, they stated here also that by using single file systems, we have a faster preparation time rather than using a full sequence rotary files. And by that, we are reducing the shaping time and allowing us to spend more time refreshing sodium hypochlorite and activating it to enhance the clearing and disinfection of the root canals. And at the end, we have the apical canal preparation here. As stated by Dr. 𝗿𝗂𝗆 in the mechanical objectives of the root canal treatment, we need to always keep the apical foramen as small as practical. Why? Because if we try to shape the apical foramen, we will only be ending up on destroying actually or transporting the apical foramen and making the later stages more complicated, meaning the final apical engagement using hand files and the gauging of the 𝗿𝗀𝗀𝗆 where we will lose that precious apical tuckback that we need, especially if we use more serious or advanced obturation technique like warm vertical compaction, where we need a lot of apical tuckbacks so that we won't be afraid on pushing the obturation material and even the 𝗿𝗀𝗀𝗆𝗀 outside the apical foramen into the periapical region. So this is a study on how does intentional apical foramen enlargement affect the foramen actually and the root canal morphology. They shaped the root canals here 1 millimeter prior the apical foramen up to the foramen and 1 millimeter beyond the foraminal, the apical foramen, and they have concluded that the mechanical preparation at the foramen or 1 millimeter beyond resulted in foraminal enlargement, transportation, and were not able to touch all root canal walls that delimit the foramen. So this means that we need to keep away of the apical foramen and do not try to shape actually the foramen, because we all know that the canals are not circular, they are oval. So even if we try to shape the apical foramen, we won't be touching all the walls around the foramen itself. This is another study on the foraminal deformation after enlargement of the foramen with rotary and reciprocating kinematics. And the results are that both kinematic promoted deformation at the major foramen regardless of the working length established, meaning that we need to keep in mind that mechanical objective that I was talking about, to keep the foramen as small as practical and to avoid shaping this foramen at the end of the shaping procedure, but only to do the apical gauging using hand files, so that we will determine the size of the 𝗿𝗏𝗃𝗀𝗃 that we are going to be using in the obturation step. For all of this, we can conclude that the reciprocation actually extends the lifespan of all types of file tested. Both of the reciprocating and rotary motions have similar cutting efficiency and does not reduce the cutting efficiency. As I said before, kinematics has nothing to do with the cutting efficiency, but the mechanical perspectives of the file. The reciprocating files shape the canal systems well and preserves the original canal anatomy. That is the principle of the minimally invasive endodontics, to preserve the original canal anatomy. Also, the reciprocating single file uses reduces the shaping time compared to full sequence rotary systems, and dentin microcracks occur independently of the type of file and its kinematics. So it continues to be a controversial topic actually, but here I show you a lot of studies where they confirm that both of the kinematics actually produce minimal actually stress on the root walls, causing cracks. But in my opinion, the size of the taper actually on the files have a greater role here on the producement of cracks. So we need to be more careful when choosing the size of the taper of the rotary files, meaning we do not need to go above 0.6% taper if you want to stay in lane with the minimally invasive concept. The ability of the reciprocating files to extrude less debris than rotary remains a matter of debate, and the reciprocating files are effective in removing root canal filling material in less time as compared to rotary, yet no system is able to remove the filling material completely from the root canal system, and that is why we need to be using additional irrigation techniques such as ultrasonic activation techniques, so that we will clear all the obturation material left in the retreatment case. These are the final minimally invasive requirements that we need to follow if we want to be practicing minimally invasive endodontics. First of all, the respecting the structural integrity of the tooth, following the original canal anatomy using rotary files with adequate taper, and keeping the apical foramen as small as practical. So we will be starting first of all by using a more individual approach in the choosement of the access cavity designs on each and every of our root canal cases, to save as much of the precious, especially pericervical dentin, as we can. And also be choosing our sizes of our taper, rotary file taper, wisely, and not go above 0.6% taper for the shaping files, and especially avoiding the usement of large tapered orifice opener files, where they can destroy the pericervical dentin, which acts as the most crucial part of the minimally invasive endodontics, and also for the fractural resistance of the tooth and its longevity. And at the end, the keeping of the apical foramen as small as practical, as the mechanical objective states from Dr. Schilder. We don't need to go shaping the apical foramen because for sure we will end up with transporting that apical foramen and bring more complication in the later stage of the obturation of the root canal systems. Now, I will show you the rotary system, actually the reciprocating system brought by Fanta Dental Materials that accomplishes all the goals that we mentioned in the minimally invasive endodontics, and that is the R1 mini kit. That it contains 2 reciprocating file and 1 orifice opener. It is a very efficient, flexible, and user-friendly kit, a small kit that it's really easy to use because there are not a lot of instruments or a full sequence of instruments. And as we said, the time for shaping or the shaping time is reduced when using, of course, less files. We start with the first file of the kit. This is the orifice opener file, a 1905 various taper file. What is so special about this file? You can see the maximum diameter of the file is only 1.1 millimeter, and that goes for the excellent preservation of the pericervical dentin, as we are required if we are using the minimally invasive endodontics. And we use this file in continuous rotation, maximum 250 RPM speed. After that, we'll be using the glide path file in this kit, or the 17 4% taper variable taper. It is the maximum diameter actually is less than the previous file, is 0.8 millimeters, and we use this file in reciprocating motions, meaning 150-degree counterclockwise and 30-degree clockwise. The R1 mini kit, they all have the double S cross-sectional design, and they have hybrid mechanical preparation, all of them, meaning that the glide path file and the orifice opener file are in the AFL group of nickel titanium instrument, where they have more of the austenitic properties than martensitic, and the flexibility here this file has from the smaller taper. And the last file in this kit is the 25 6% variable taper file that has the same maximal diameter as the first file, 1.1 millimeter. We use this file in reciprocation like the previous one, 150 degrees counterclockwise and 30 degrees clockwise. This file actually is the most flexible because it goes in the AFR group of nickel titanium, meaning it is a martensitic file that contains more of the martensitic properties than the austenitic, and we can easily pre-bend this file before entering the root canal system. I will be showing you now some of my cases that I've done with the R1 mini kit. This is a lower molar, as you can see on the pre-op. The access cavity design here was actually made by the patient itself because he had a very big MOD restoration, and that ended up with fracturing alongside with the lingual wall of the tooth itself. I'm only locating the orifices of the canal here with ultrasonic tip, trying to be minimally invasive in this area where the pericervical dentin is, as we talked before. This here actually is a 4 canal lower molar, and in these cases I always go for the straighter root canals, or the mesiolingual and distal buccal. This is the orifice opener from the R1 mini kit, 19.05% taper. We just go slightly, a couple of millimeters inside the root canals. Here you can see the debris packed into the flutes of the rotary instrument. We always need to be cleaning the flutes. My assistant uses sterile gauze damped in alcohol for this to let the file shape inside the canal, sorry. After the orifice opener file, I am determining the working length with a 10K file. As I said before, in cases with 4 canals, in lower molars, I always go for the straighter canals. This is the mesiolingual canal, and then I will be scouting the distal buccal. And after I am done shaping these root canals, I'll be determining the working length on the other canals. And in cases where they are joining each other, I will have less time to prepare the other 2 canals after deciding if they are joining or not. Now I'm using the glide path file, the 17.4% taper, reciprocating movement, 150 degrees counterclockwise, 30-degree clockwise. You can see how easily it's going all the way to the working length. Of course, the chamber is full with sodium hypochlorite. We always need to replenish the irrigants inside our root canal systems when shaping. There I finished the mesiolingual canal. Now I'm going to the distal buccal, always cleaning the flutes, 2 or 3 strokes, not pressing on the file, cleaning the flutes, then irrigate the canals, check for patency, and go with the next file. Here I'm cleaning the debris of the root canal shaped, checking the patency. All the canals that I have prepared, the sodium hypochlorite. And now I'm using the final rotary instrument in this kit, the 25.6% taper. Again, reciprocating motion, 150 degrees counterclockwise and 30-degree clockwise. You can see how easily I'm gaining the working length. And if you saw in the pre-op picture radiograph, you can see that the canals were actually highly calcified. So it is not an easy case, but with the R1 Mini, I have completed it with no such effort. Again, using the 25.6% taper on the mesiolingual canal now. After finishing with this file, then I go for the other 2 canals. First of all, to check if they are to measure the working length, and then to check if the canals are confluent with the previous canals that we already shaped. Here I'm clearing the debris before entering the 2 additional canals. Here, this is the distal lingual. Most of the lower molar cases where there are 2 distal canals, maybe 90% of the cases, the 2 of them are confluent. So I advise to go for the straighter one or the distal buccal, and of course on the mesiolingual. And if they are confluent, we will have an easier job to be shaping the more curved ones, or the mesiobuccal and distal lingual. I'm entering the final rotary file, the 25/6% R1 mini, in the mesiolingual canal that I have already shaped. And this is the 10K file in the mesiobuccal canal. As you can see that here they are confluent, they are joining each other. I am measuring that length. And I will be shaping the mesiobuccal canal all the way to that working length. Again, here in the distal canals, they are also joining each other, and we will be using the glide path file now. It will be really quick now because they are with a shorter working length. After the 17.4% taper file, we're going with the 25.6%. You can see the debris packing into its flutes, and we need to clear out the flutes before re-entering the file inside the root canals, so that we will have a greater cutting efficiency. These are the canals prepared, actually. You can see better after I suction with the intercanal suction tip here. You can see that I have kept the pericervical dentin as much as possible. And in this case, because the patient had pain on percussion, I decided to go for a 2-visit treatment. I use calcium hydroxide here for a additional disinfection, because the canals are confluent. When placing the calcium hydroxide inside one of the canals, it goes in the other one. This is the post-op X-ray. After 10 days, you can see the master cone radiograph before the obturation. I'm always using the final rotary instrument used for pushing the calcium hydroxide deeper into the apical region, but on the other side of the cutting angles, on the different sides, so we don't cut the dentin. And this is the post-op of this case. You can see the slim shape of the root canals. And that is it with this case. We go on the next one. This is a retreatment case, actually. Here, as I said before, that we need to have more individual approach when choosing the access cavity design. Here, I am choosing the restoration guided access design and not cutting more of the tooth structure to be, of course, minimally invasive. And I only take out the restoration. I even left the mesial wall to have a chamber that I will fill with irrigants later on. I just melted the obturation with the ultrasonic tip. And here I'm using first the 25/6% taper, or the final file of the mini kit, to take out the old filling, take out the old obturation material of the root canal. You can see big pieces of the 𝗿𝗄𝗺𝗺 coming out. Very easily going through the obturation material. But I always measure from the pre-op X-ray and go 1/2 of 1 millimeter short of the previous obturation made in the root canal. And I finished the job with headstone files to pick out the root canal from the most apical region of the obturation material. you can place, this is the 𝗺𝗃𝗀𝗆 file, clockwise direction, and there it is, the apical part of the gutta percha used. Once again, and that's it. Now we need to give some irrigation. We need to use also activation on the irrigants inside the chamber to clear out the debris and also the previous obturation material. Now, after taking out the obturation material, I am establishing the working length using 10K file. And after that, I will be using the same sequence, starting with the 𝗫𝗚𝗘 file. Actually, we do not need to use the orifice opener file here because we were using the 25/6% and they have the same maximal diameter of 1.1 millimeter. Very quickly up to the working length with the 17.4% taper, and now I go with the 25/6 taper file again, but all the way to the working length. Now, after scouting the access cavity, I found an additional lingual canal here that wasn't treated previously. I am using the 10K file on determining the working length. I actually didn't extend the access cavity design more lingually because with this kind of file system like the R1 Mini, which is flexible, we can preserve the tooth structure as much as we can because they can finish the job quite well. I'm using the orifice opener here. Now trying to see if the two canals are confluent. Many of the lower premolar cases with 2 or 3 canals ended up in joining each other, but not this one. It happens that it had different foramen. I'm using the 𝗫𝗚𝗃 file here, 17.4% taper in reciprocating motion. And you can see how quickly I went to the working length of that root canal or the lingual. Now checking the patency. Again, recapitulation and using the final file here. Actually, it was a thinner canal than the buccal, but that was no problem while using the R1 Mini. I shaped it with the 25/6% as well. And here I'm using the sodium hypochlorite and of course some ultrasonic activation. I always use after finishing the shaping procedure. I'm using the 𝗢𝗚𝗘 Pro here by Fanta Dental, which is a ultrasonic activation device. I activate the sodium hypochlorite here, not just in the lingual canal, but in both of the canals, of course, in the buccal one, to clear out the debris, to give additional disinfection here, and to take out all of the remaining obturation material of the buccal canal. This is the master cone, and this is the post-op radiograph. As you can see, I did not even touch of the residual tooth structure on this tooth, if you can compare it with the pre-op image. And that it is. This is another case here where I used the R1 Mini retreatment on a lower molar. I used the same sequence as I showed you in the previous video. I used the 25/6% taper for taking out the previous obturation and the distal and mesial canals. Then I made an initial negotiation with small hand files. And after that, I used the 17.4% taper file for the glide path management and the 25/6% taper for shaping and finishing of the root canals. And you can see the post-op image on the right after finishing the endodontic procedure. This is also a lower molar with quite curvy distal and mesial canals. I use the R1 mini kit here as well, using the same sequence I showed you in the first video, the orifice opener file, then the R1 mini glide path file, and later on the 25/6% for shaping and finishing. And you can see how well is does the obturation looks. So if we can summarize from all this, the R1 mini kit is actually a 2 files reciprocating system working in 150 counterclockwise direction and 30-degree clockwise. It has a great cutting efficiency while shaping the root canals, and it is a minimal invasive file system that preserve the tooth structure. As I showed you, the maximum diameter of the files is 1.1 for the orifice opener and the 25/6% taper, and 0.8 millimeters, only 0.8 for the glide path file. It has a high flexibility and less torsional fatigue, and that makes it safe and predictable for the instrumentation of the root canals, and of course user-friendly like every reciprocating file system, especially for the beginners of the endodontic procedures. These are some of the various stepping stones that you need to keep in mind if you want to practice minimal invasive endodontics. First of all, utilizing advanced imaging modalities for better understanding the complexity of the root canal system, like CBCT scans. I use them not for all of my cases, but I use them for the retreatment cases to come up with a great treatment plan that I will later on execute it with safe and predictable root canal retreatment. Employing higher magnification and illumination for visualizing the pulpal space, you can be using loops like 5 or 6 times magnification, but the best way to be practicing minimally invasive endodontics is to be using dental microscope. You need to be using new instruments, irrigants for cleaning and shaping the canal systems. As I showed you, the R1 mini kit here accomplishes every requirements, every goal of the minimally invasive endodontics. Also applying newer material that increase the prognosis for restoring structure and retaining the natural dentition. And at last, long-term endodontic treatment success must integrate respect for the concept of minimally invasive endodontics while fulfilling treatment's mechanical and biological objectives, well described by Dr. 𝗿𝗂𝗆. As I was talking about in the beginning, we need to be minimally invasive in aspects to conserve as much tooth structure as possible, but also to do so without compromising the other objectives that we are required to do in the later stages of the root canal treatment, or the mechanical and biological objectives described by Dr. 𝗿𝗂𝗆. So I thank you for your attention. If you have any questions, I'll be more than happy to answer them in the comment area. Thank you, and we'll be seeing each other very soon.